Well, this week in the Cardiology Countdown, we have an array of studies. The first was published in JACC, looking at the very hot topic of clopidogrel and when to discontinue it prior to CABG, and specifically whether platelet testing could assist in the decision-making. This study looked at 100 patients, and they followed a protocol where half of them had the aspirin and clopidogrel stopped just 1 day prior to CABG, and the other had it stopped 3 days prior to CABG. And they integrated into the protocol platelet testing using the thromboelastography test, or the TEG device. The big finding was that the day of stopping, at least between day 1 and day 3, didn't appear to have a big impact, but the level of platelet function did, whereas those with the highest level of platelet inhibition had a significantly higher risk of bleeding, whereas the lower two tertiles of this test did not. And so it's just an initial study, but suggestive that platelet testing may be useful in guiding who could safely go to coronary bypass surgery earlier than the guideline recommended 5 to 7 days of stopping, where one could be totally sure that the antiplatelet therapy had worn off. At the second spot, we have new guidelines from the American Heart Association and American Stroke Association for primary prevention of stroke. It's a comprehensive guideline looking at multiple therapies. It notes that risk stratification is a key factor for all patients, and that's something we do in ACS, but is now strongly recommended as part of the initial management. Then good blood pressure control is recommended, and specifically in diabetics, a goal of less than 130/80, supported by the recent ACCORD study for stroke prevention in any case. Use of angiotensin receptor blockers or ACE inhibitors is recommended for blood pressure control, again in diabetics. Statins are recommended in all patients with the clear indication. And adjusted dose warfarin is indicated in patients with AFib. Now, it does not adopt what the recent AFib guidelines did by the ESC of anticoagulation for a CHADS-1 patient. It does say either antiplatelet therapy or anticoagulation. So it's a comprehensive guideline for helpful to take a broad look at stroke prevention. And then finally, we have another study with the novel anticoagulants. This is the Einstein DVT and extension study looking at the treatment of documented deep vein thrombosis. A large study that used rivaroxaban, an oral 10A inhibitor, in just about 3,500 patients, compared with enoxaparin followed by warfarin. And it showed non-inferiority of use of rivaroxaban, a 15 milligram twice a day dose for 3 weeks, and then 20 milligrams a day. And this had a hazard ratio of 0.68 and a confidence limit going up to 1.04, so close to superiority, but clearly showing non-inferiority, and no difference in bleeding of these two strategies. Then a separate study looked at anticoagulation beyond the 6-month time period, so rivaroxaban 20 milligrams a day versus placebo, and found an 80% reduction in events with just a 0.7% risk of major bleeding in the treated patients. And as such, it adds to the body of literature that extended anticoagulation following DVT can be useful. And so a very broad group of studies this week, but I think many that will advance our practice. So for the Cardiology Countdown this week, I'm Chris Cannon.